Managing Director of the COVAX facility, which is hosted at Gavi, the Vaccine Alliance, as Jeremy just mentioned. I'm going to give you a very whistle-stop tour through some of the work we do and really ground it in terms of how procurement for vaccine has changed as a result of the work that Gavi does, but has also raised a lot of questions, and some of these questions I'm going to be putting back to you. So Gavi is an alliance. It has quite a lot of actors involved in it, which you can see here. First and foremost, of course, the beneficiary countries who are implementing vaccine programs, the donors, technical partners, civil society organization, the vaccine industry, all of which come together to be able to facilitate immunization in developing countries. And really the view that Gavi has done over the last 22 years is how to bring together immunization to support healthy communities and healthy economies. And that's translated through, in practice, vaccinating over 888 million children, which when you vaccinate that many people, you prevent 15 million future deaths from taking place. You generate $230 billion in economic benefits. And you do so in a model that's sustainable over time, so that when countries become more and more rich and can pay more and more for their vaccines, over time, they are no longer dependent on donor funding and can procure vaccines and sustain their immunization for themselves. And so this is the trajectory over the years since the inception of Gavi from 2000 in terms of numbers of immunized children across a range of vaccines, and very much charting the course in terms of making sure that the coverage in low-income countries is as good as, or as close as possible to those in richer countries. So it's about having impact at scale. It's also about having access across a very large vaccine portfolio. So what you see here is over time, these are the different antigens that went into vaccines to be able to help address vaccine preventable diseases that were causing huge mortality and morbidity in developing countries. And so it's the Gavi model in terms of procurement really is around very large footprint in terms of numbers of countries that are covered, and therefore numbers of people immunized, and also across a very large portfolio of vaccines. And so what you get when you have a very large pool is you have the ability to negotiate and achieve affordable and sustainable vaccine prices. So this is showing you sort of visually when you think about how much it costs to immunize a child with a full course of vaccines around hepatitis, DTP, HIP, Rota, etc., that you can see here. From a Gavi perspective, when we negotiate through a pooled procurement model, we pay on average about $28 for a full course to immunize a child. And that compares to for the same diseases that are vaccinated in the US against an approximate equivalent price of $1,200. And the Gavi model is really meant to be one where it evolves over time. So for countries that have the least ability to pay, so those to the left of the low income threshold, which are low income countries, all they do is very much have a very nominal amount to pay towards their vaccine, to have some ownership of it, but recognizing their very weak ability to pay. And then as countries progress in terms of their economic status over time, they will enter the next phase, the preparatory transition, accelerated transition, and then ultimately come to a point where they are fully self-financing their vaccines, their vaccine programs, and transition out of the Gavi model. So when you don't have a suitable product for a low-income country, this is where the Gavi model helps provide this predictability. You have on the one hand, the vaccine needs of the low-income countries. You have on the other hand, the business needs of the developers. And then in the middle, the Gavi piece does the financing planning to help bridge this gap and ultimately encourage countries to take ownership of their vaccine program so that it's sustainable over time. And so that applies also from a pooled procurement basis, where you have large and predictable volumes. We know how many children are born per year in the world, roughly speaking. And so you take a pool where even with a large, you have a large pool of countries, but even within it, you have large countries. So the top 10 Gavi countries on a population basis that are Gavi supported, I'm excluding India, just given the sheer numbers in one country, account just for themselves to 61% of the overall population. And so the stability of the pool relies on having a critical mass where you have a large number of participating countries and you can build and plan around it. At the same time, you're also always going to be dependent on not having all of the large countries go too far up or down, because obviously the volumes affect the stability of the pool for those large countries. So that's the Gavi model overall. Within that, when COVID hit, we built COVAX. And so let me just give you a little bit of background about COVAX and some of the pool procurement questions that arise. So for 2022, we've been very much building the foundations of COVID-19 protection with vaccines, very much with a focus in lower income countries, deploying what we've built over time as a flexible and reliable portfolio of vaccines so we can manage the uncertainty of the pandemic, we can anticipate risk, and we can create a pool for future vaccines. And we support delivery at scale so that countries can reach their coverage objectives. So within COVAX, we have a little bit the same model here, where you have on the one hand participants who, what we do with the COVAX facilities, we pool the demand and their financing, we consolidate their buying power, and we give them access to a broad and an actively managed portfolio. And on the other hand, on the manufacturer side, we provide manufacturers access to a massive and a demand assured market that has donor funding backing and country funding backing. So what this has gotten to it's not been an easy ride, but overall, as we stand today, we've allocated over 1.9 billion doses. We've shipped over 1.4 billion doses across 145 countries to really support the COVID-19 rollout globally. And COVAX is the biggest multilateral agreement since the Paris Climate Agreements. And so within it, we want to make sure we have a view on the totality of participants. So we have ODA, so donor finance countries, and we have self-financing participant countries. And this is important for a couple of reasons. The AMC participants who are donor funded are the lower income countries who really need to benefit from donor funded doses and be able to have technical support in place. And then on the other hand, you have self-financing participants, and these are the ones I'll talk for a little bit more, which are, so these are upper middle and high income countries who want to benefit from the COVAX portfolio, from COVAX negotiated prices, and who can have different models to get coverage for their countries, as well as can have access to procurement mechanisms. And so we built a facility that was global, which had these sort of two groups. And within it, we have a lot of interesting procurement questions vis-a-vis the self-financing participants. So we built two models. One is the optional purchase agreements. So for countries who pay for their own vaccines, they're not donor funded, they can have a higher upfront payment, which gives them the ability to decide which vaccines they want to buy. Do I want vaccine A or B or C or only A and B or any permutation? And share a little bit of a risk-sharing guarantee with the facility. The other model that we have is a committed purchase arrangement, where if you're a self-financing participant, your payment upfront is lower, but you do not have the ability to choose vaccine A or B or C. It'll be a question of whatever vaccines are in the pool, the countries will have access to them. So there's different models that we've used, and it's been really interesting to see what are the incentives for countries to join. So in the end, we had 95 countries join as self-financing participants. And the things that mattered to them were, what's the timing of delivery? Because during a pandemic, the most important thing was to be able to get vaccinations going as soon as possible. Is COVAX going to get me doses faster than I'm going to get through a bilateral deal that I'm going to negotiate directly with manufacturer A or manufacturer B? What's the price that I'm going to get? Who else is in the pool? Am I on my own or am I with everybody else? How long is my commitment going to be for? How much do I need to pay upfront? So these two different models. And do I need to be an exclusive, to have an exclusive source? Do I only need to buy through COVAX, or can I buy through COVAX and also do bilaterals? As many of you will know, that we ended up with the latter, where countries could buy through COVAX and through bilaterals. But it was all of those questions very much that we had to take into account. And ultimately, I think the result that we saw somewhat varied in the sense of a number of self-financing participants in either model, optional purchase or committed purchase, were heavily reliant on COVAX because they could not strike bilateral deals themselves. And so COVAX became a really important source of vaccine for them, particularly if they were upper middle income countries, if they were small countries. What we saw for other participants is COVAX was more like an insurance policy. They were able to get their own bilateral deals, but it was always good to have, if ever COVAX would have vaccine D, which they, for some reason, didn't have a bilateral deal for, and ended up being interesting, or as a little bit of a backup mechanism. So I'll stop here, but that's the experience that we've had from our perspective in terms of how we've looked at procurement in Gavi overall, particularly within COVAX in this pandemic period, and grappling with a lot of the different issues around what are the incentives for people to join a global pooled procurement mechanism, which ultimately was a multilateral answer for having the vaccines in place to address the pandemic. So I'll stop there and hand back to you, Jeremy. Thank you.
Thank you very much, Aurelia. I suggest that I see some questions are sort of coming up here. I suggest that we all take a bit of time of reflection and maybe type the questions that we would most like Aurelia to respond, to answer as part of the following ensuing Q&A. And so I will be monitoring those questions as the rest of the other two presentations unfold, and sort of hopefully all three speakers may have perspectives on some of the questions. So, I will now give the floor to Brenda Waning, and for those who joined us a little bit later, Brenda is the chief of the Global Drug Facility within the Stop TB partnership. So we're really excited to have you here, Brenda, and look forward to your thoughts.
Jeremy, does this look okay, or?
Yes, I personally can hear you great and see your slides really well.
Okay, great. So thanks very much for the opportunity to speak with you today. Shifting from Aurelia's presentation, which was on vaccines, we're going to move into a case example on medicines procurement. And in this particular example, tuberculosis or TB medicines. My organization, the Global Drug Facility, we go by GDF, it's about 20 years old. It was established in 2001, and it is a UN entity. So it's an enterprise within a partnership that's hosted by a UN organization. And we are the largest buyer of TB medicine diagnostics for the public sector in the world. That said, that's not a big business, about $300 million per year. It's a small market, we'll get into that. And that gets spread across more than 120 countries. I would like to say up front that while the the procurement part of our business is by far, a very key component. It's not all that we do. And the goal of the organization really is to increase access to innovative, affordable, quality assured TB medicines and diagnostics. That's the goal. Procurement is one of many tools that we do to try to meet that goal. And from the beginning, GDF has been a model that has combined pooled procurement with other tools and services that have been developed and enhanced along the way to meet the changing needs of the market and the needs as things have evolved. So if you look at the image on the bottom here, it's really an end-to-end market stewardship model where you're really trying to figure out, what's needed. How do you get suppliers to develop it? How do you make sure it makes it through the regulatory process and doesn't get stopped? How do you get it into countries? How do you monitor, and how do you help suppliers when they have to phase out? So it's really an end-to-end service that we have. In terms of TB, it might be surprising for people to know that it's one of the top infectious disease killers in the world. And people, when I'm back in the US, are always surprised to hear that. Up until COVID, it was the #1 infectious disease killer in the world. But it's largely a problem in low and middle income countries. And there are two types of TBs called drug sensitive TB, where it's sensitive to the typical drugs that are used for it. And then drug resistant TB. You've probably heard of DRTB or MDR-TB. And this is really deadly. So it has a mortality rate of 60, 70% untreated. Even treated, it has a pretty high mortality rate. And in terms of numbers, about 10 million people get it per year. About 1 million are kids. And just a little over half are actually treated. So there's a huge gap. And within the drug-resistant TB, there's only about 150,000 people treated per year. So that's the market you're talking about across the entire world. 150,000 people, it's small. I want to go through a specific example about what we've done with regards to developing the market for pediatric DRTB medicines. We've developed a market for adult medicines. None of them exist. This markets didn't exist before GDF was established, but I'm going to give you a concrete example of the most recent market that we've evolved, and that's treatment of kids for DRTB, drug-resistant TB. So just to put things in perspective, the total possible number of kids out there, somewhere between 10 and 12,000 kids under 5 that get this deadly disease. Most of them will die if not treated. Less than 2,000 kids are treated per year. That's the global market. And then in terms of the number of countries, there are more than 100 countries that need these medicines. So those 2,000 kids are spread across 100 countries. To make matters even more challenging, the WHO recommended treatment consists of 11 different medicines that can be put together in all kinds of different ways to have countless different regimens. You need 5 to 6 medicines per treatment course, so you need a lot of medicines, and it's a 12-month treatment. On the supply side, it's very challenging. In general, but especially for these products, TB medicines are not like other medicines where suppliers just make them continuously and they're on the stock, they're on the shelves and they have inventory. Everything is made to order. There's no inventory. When you need 5 to 6 medicines per regimen and you're trying to spread that across 2,000 kids, you've got different suppliers with different batch sizes and different lead times. And it's a lot of work to figure out how do you organize all of the orders and place them with all the different suppliers to get them to all the countries that need them at the same time and organize production with the suppliers. I'm trying to figure out how to move my, let me just see here, sorry. Okay, sorry. Okay, and then for, here we go. For orders, we're really talking about if you've got 2,000 kids across 100 countries, very small numbers of treatments needed per country per year. So for this particular product, we have orders coming in for less than 10 treatments per country per year. We have some countries literally ordering 1 or 2 treatments per year. And can you imagine any supplier that would be willing to deal with that headache if the countries are going to them directly? It just wouldn't happen. So we've been quite successful, despite all of these challenges, to create incentives for suppliers to make these products for what is a failed market at best, if not an absence of market. So for all of the 11 recommended DRTB medicines for kids, you can see the launch of the different products since 2018 until today. And so now we have all of the medicines available in pediatric form. And just to say, even though the global market is 2,000, the GDF market you can see here is less than 1,000. So we're really talking about a small number of treatments. And despite all these challenges, for the blue medicines, we actually have 2 suppliers per medicine. So it's kind of like unheard of success, in addition to 30 to 80% price reductions across these products. So this system that we put together is clearly working. It's encouraging innovation where innovation really shouldn't happen. It's getting the best products to people who need them in the best formulation at the best price. And then we also track introduction. So these are just uptake curves and experience over the years with different products. These are the DRTB products, the red, green, and purple that we've just most recently introduced. And you can see the slope continues to increase, which means uptake is getting quicker. And so we're able to not just encourage suppliers to make them, but then work with the partners in WHO and all to get them into countries. And that really encourages the suppliers that, okay, if I put the effort into making something, you're going to decrease my risk and somebody's actually going to buy and use them. And that's huge for the suppliers. So what we try to do, very similar to what Aurelia presented, is really find the win-win-wins for clients, suppliers, and us. And really, if you think about pooled procurement, the role and value really depends upon the size and the nature of the national market and the global market, but right down to the formulation level. I'm not talking about the size of TB in a country, but you really have to look at the different products that they need to figure out whether or not pooled procurement and other things around it will help. So what's made us be successful is that we can make ourselves available to every country. If you can legally buy through GDF, you can come. We even have, for example, Australia buying through us. And all types of clients. We have NGOs, governments, donors, researchers, all kinds of people buying from us. We do have prepayment mechanisms. We have our own packaging in 4 languages, and this is a huge thing that reduces transaction costs for suppliers. They don't have to deal with adhering to country-specific packaging requirements. And then there's one packaging that the 4 languages cover most of the world. Just about everybody we supply to can read one of the languages. So then the client gets something that they can read as well, which often doesn't happen. We have the ability, because we have a warehousing function, so that when you need 5 to 6 medicines for a regimen, you don't want to send them one by one, because it's a lot of work for the country. It's a lot of work for the suppliers. And you want them all at once so you don't develop resistance. So all of those medicines from the different suppliers go to our warehouse and they get shipped into one shipment for the country. So they have everything that they need in one transaction. And the supplier only has to ship to our warehouse in Amsterdam instead of to 120 countries. We have international quality standards, so you don't have to worry about quality. We can support suppliers with registration, again, decreases their transactional costs. And we have the ability to use waivers when relevant because we're a UN entity. We do a lot of work with demand review and production planning so that it helps the suppliers in saving money so that they're not having idle production lines and losing money that way. We have a unique thing that I won't have a lot of time to go into, but the strategic rolling stockpile, we actually purchase inventory and put it in our warehouse. And we take on the risk of holding that inventory and hopefully that we can sell it. And that is basically, it decreases dramatically the transaction costs of suppliers, because instead of doing, let's say 100 purchase orders to a supplier, 160 purchase orders to a supplier in a year, they do 12. And again, they make 12 shipments to our SRS instead of 160 to countries. And we take on the risk of holding the inventory because we own it. And what this allows us to do is we can much more quickly introduce new products, and we can really respond immediately to protect countries when they run out of medicine. Because remember, everything's made to order. And if somebody runs out of a medicine today, and they put an order in with the supplier, they're going to have to wait 6 months for that product. So that's been a really critical thing to helping countries and suppliers. We also do a lot of work on rational use. We have a catalog that guides people on what WHO recommends and what it doesn't. We really validate against orders against, are they consistent with WHO recommendations? We validate the quantities they order to make sure that they don't over or under order. We help with adverse drug event reporting. And a lot of work on expediting new product introduction. That's done in close collaboration with WHO and all of the other implementers, and we take the lead on the supply management side of that. We supply to clinical research studies. It's a hugely onerous thing, but I think we're supplying to over 60 trials now. And that's a really critical thing. If you want innovation, these researchers have a very hard time securing products for their studies, because first of all, they don't know how to buy. And second of all, they're such small quantities, nobody wants to supply them. So that helps with the innovation. We are constantly in keeping track of what's happening with the research, where the market's going to change, and giving that to suppliers in advance, so that they, once we know that something is going to be coming forward, we get them to start making something early on, so that by the time it gets through WHO recommendations, it's ready to be purchased and sent to countries. So a lot of work on partner coordination, global policy, and that sort of thing. So where does this leave us now in summary? So overall, in summary, the TB market, it's very small. And unlike some things like, some of the vaccines, HIV medicines, you don't have that same opportunity to leverage innovation and sales from high-income countries. So TB suppliers aren't making and selling a lot of new TB drugs in high-income countries, and they can then kind of give a better deal to low and middle income markets. So it's challenging that way. Good news, bad news, all of the studies going on now are towards treating TB for a shorter time. So it used to be treated for 18 to 24 months. And now the studies are coming up saying we're probably going to end up in 6 to 9 months. So we're going to, just from that, see the TB market that's already small. Remember, about 150,000 people per year treated for DRTB. It's going to decrease by at least 50%, just because duration of treatment is decreasing. So it's going to get even more challenging on the demand side. The current systems that I've described to you, they've been really successful. But that's because we had control of a lot of the factors, because the donors had stipulations that allowed us as GDF to create this fairly homogeneous market that, while fragmented, it was as consolidated as possible. So we had consolidation around about 10 quality assured global suppliers, because they had to meet very high standards. We had consolidation about what drugs were used, because the donors required that you use those recommended by WHO, and the same with the formulation. So the WHO and the donors said, if there's a pediatric formulation available, you have to give that to kids because that's appropriate. If there's a fixed dose combination product where 3 drugs are in one, you have to give that to people. And so we had these donor policies that linked to WHO recommendations that allowed us to do as much consolidation as possible. And that was great, and that got us where we are. What we now see is a shift. So the big shift is from donor funding to domestic funding. And if it's domestic funding, that means domestic procurement. So instead of a country coming to us, they might procure to go on their own. So as Aurelia was mentioning, we have already lost some big countries that kind of anchored our volumes, and we will probably lose more. And because we no longer have the donor requirements that allowed us to consolidate, those are gone, right? So what we're going to see is, in addition to a very small market that's getting even smaller, we're going to see increased fragmentation. So we're going to see more suppliers because suppliers exist. We only chose the highest quality suppliers, but there are lots of other suppliers out there because TB has been around for a century. We'll see an increase in the number of medicines used, in different types of formulations and quality standards. So it's going to get really messy. I mean, right now we're doing okay. We're able to hold it all together. But going forward, what we're really going to have to think about is, how do you strike that balance? Because clearly pooled procurement is not the be all end all. It shouldn't be used for every drug, for every country, for every situation, but there definitely is a role for it for certain drugs, certain countries, et cetera. Clearly TB is one of them. But in order to do that, you need to have some type of buy-in and trade-offs from countries who could otherwise go on their own. You need common goals, you need similar policies that will create a harmonized market that allows the innovation to continue, the access to the best products to continue, et cetera. And so that's where we are now.
And I'm so sorry to interrupt you. I just wanted to give you a warning that you might want to conclude your talk relatively shortly, so we can.
Yeah, I think that was my last comment. So yeah.
Right, thank you. I'm so sorry. I hope I didn't interrupt you or. Okay, fantastic. Thank you very much, Brenda, for sharing these thoughts. And without further ado, I'll leave the stage to Prashant Yadav, who is a senior fellow with the Center for Global Development and an affiliate professor with INSEAD. Thank you, Prashant. And so maybe if you could keep to about 10 minutes roughly, so we have a bit of time for questions.
Give me a second, Jeremy. For some reason, my slides aren't moving forward, so might be another minute. My computer is frozen for some reason, Jeremy. I'm going to try to do without slides, and I'll try to keep us on time to the extent possible. So thank you to everybody. Thank you, Jeremy, Georgia, Anant, Pavitra, for organizing this. I think it's a great opportunity to share a lot of interesting things that are happening in global health and operations, particularly at the intersection of IO theory and operations, where I think a lot more can be done. And hopefully this seminar will motivate some such work. One thing which is a hotly debated topic in the world of global health more recently, but has always been, is what is the right locus for procurement? And Aurelia and Brenda showed us two examples from the vaccines market and for the TB drugs market. The Global Fund does for other medicines such as antiretrovirals for HIV and malaria medicines. But one question that still remains unclear is, do we have the analytical machinery to create a strategy grid which can say, here are the characteristics of the market, here are things that I will use to define a market archetype, and then use that archetype to say that the locus of procurement for this archetype should be global, should be regional implying in Africa, for Africa, or in Asia for Asia, things like that, or national, or perhaps in some cases even subnational, right? So that strategy grid is not, at least the people we work in practice don't see that as clearly. So I think there might be an opportunity to think about that. The second point is related to the benefits of pool procurement. I think some parts are very clear: reduction in price, reduction in lead time on an average, not necessarily in a distributed sense, but at least on an average. But there are questions about static and dynamic efficiency. So static efficiency implying, okay, we got lower lead time, we got lower price, but is it improving the market in a dynamic sense? Is it creating new suppliers? Is it bringing competition? Is it bringing innovation? So when you look at static and dynamic efficiency together, it leads to some more interesting questions that are not as clear and obvious in a static efficiency model. So that's one part. Then is the distribution of benefits. So in an aggregate, I think we can conclude that pool procurement leads to overall aggregate benefits, but are they distributed in a way that there will be a stable equilibrium in pool procurement? And when I say distributed, what I'm implying is that amongst the countries that join the pool, some countries get more benefits, other get smaller benefits. So if you're Nigeria and you're a big country, your benefits from joining the pool on one side are equated to be the same, but at the same time, what you bring to the pool is a lot of volume. So that distributional welfare effects need to be looked at. Then I think people are asking questions as to, does pool procurement for specific therapeutic areas lead to better health outcomes? And that raises questions that Brenda brought up in her talk, which is, in order to influence health outcomes, is it sufficient to purchase and reduce lead time and reduce prices? Because if the downstream infrastructure doesn't work, then it doesn't lead to health outcome improvement. So should pool procurement groups be organized in some way in partnership with downstream delivery, like what GDF is doing or Gavi does for its routine vaccines? And if yes, what should be that partnership model? What should be the performance criteria that a Gavi or a GDF or a global fund should lay out for those who are managing the downstream delivery? So that's another question which somewhat has some nebulous elements that are not as clear in the practice community yet. Then is a question of two types of pools, which Aurelia's presentation starts to get into. When I say two types, one would be geographical proximity-based pools, and other will be income proximity-based pools. So imagine pooling countries in the world who are all low-income countries and saying, we'll purchase on your behalf jointly. The alternative would be all countries in Latin America, all countries in Africa under the African Union, the Gulf Coordination Council for the Gulf, coming together because of geographical proximity. The upside of geographical proximity is that there is already solidarity, the structures for bringing countries together exist, there's greater trust. The downsides are that we do need to think about differential pricing, because a manufacturer selling to some of the markets wants to ensure that they can get sufficient surplus, and doing differential pricing allows them. But when you have a pool which has different countries with varying income levels, then can you do differential pricing within countries in the pool? Most of the models that we see assume that the price given to all countries will be the same. This has led to a lot of controversy and debate in the past. Aurelia has been in the middle of this. And so I think that's another question, which is, when you have income proximity pools versus geographical proximity pools, and on top of that, you do differential pricing, how do you manage the pricing structure given downward to the countries who are members of the pool? And what does it do to pool stability? Is there a cooperative game which has a core that remains stable? What mechanisms create that, right? So that's a big unanswered question that came front and center when COVAX was designed. Unless we find answers to it, we will continue to remain in the cycle as to what is the right way to design that mechanism. And then the last thing I mention is, when we talk about pool procurement, often there are some activities such as countries coming together to identify what is new technology coming on the market, what is the state of market health and competition in the market, right? So those are things which are largely reducing the information risk for multiple countries through pooling. They're not about procurement. They're largely about reducing information risk through pooling. Other benefits are about reducing the transaction cost or bargaining power through pooling, right? So can we think about alternative models of pooled procurement, which are not necessarily doing all of it, but are reducing information risk through pooling and letting the transactional pieces occur independently, or vice versa? And where are the benefits maximized, and how do we do it? That's once again a question that needs answers. So I will stop here, give it back to you, to Jeremy. If you have questions, other things, I'm happy. You know how to reach me, so I'm always available and reachable. Thank you.
Okay, thank you very much, Prashant. And indeed, our Q&A session is going to be a little bit short, and some of our presenters, I mean, are really running very challenging, important operations, so they will have to leave on time as a heads up. Look, many questions in the chat. Thank you very much for all of you. There's one question that asked about the impact of COVAX on the supply. Did COVAX increase the supply? And I think a broader question relevant to all, at least the first two presenters, Brenda and Aurelia, is what are your key success measures? So maybe the quantity of supply being one of them, but more broadly, what are the critical metrics that you would look at to decide if an improvement you're considering or a different way of doing would be an improvement or not? Maybe I would let Aurelia answer that first, maybe going then to Brenda.
Thanks, Jeremy, and thanks all for your questions in the chat. So to the first question, I mean, indeed, COVAX did increase the supply of vaccines. The countries, particularly the low and lower middle income countries, would not have had vaccines produced for them had it not been for a global pooled procurement mechanism that brought together and pooled donor funding on one side to be able to convert it into firm contracts with manufacturers and then give that volume on. So those countries effectively would not have, by and large, would not have had vaccine programs. About 90% of the doses that went through COVAX went to low and lower middle income countries. And it's a really good question in terms of key success factors. I mean, ultimately, it is really around looking at the rate of immunization across the world. I think that's the ultimate outcome measure. So it's not just about how many vaccines you were able to buy, but have those vaccines also been translated into vaccinations. And so as of today, we've really managed to close the equity gap, where I think globally the average is about 59% for coverage in COVID-19 vaccines. For the advanced market commitments, so the low and lower middle income countries, that coverage is now starting to track upwards towards 45%. So it's increasing, but it's still very low in some of the poorest countries. So there is still that equity gap. And I think now that we have overall figures that are increasing, I think the other important success factor is of the poorest and most vulnerable countries and those who are least able to procure, are they getting the access that they need, and are they getting the help in terms of delivering the vaccines? Back to you, Jeremy.
Yeah, thank you for this perspective on success measure and how you. Brenda, can I go to you and ask you what your perspective is on the same issue?
Yeah, so as I mentioned, the ultimate goal of GDF is really to facilitate access to TB products. And so that's our ultimate success, and that's what we're evaluated on by our donors. And we define that as having no stockouts in the countries that we supply, and that they have sufficient supply to meet whatever their planned demand is. In addition, we have an expectation to expedite introduction of new regimens and medicines and formulations, and specific targets on that for about 40 countries. So that's like the primary measures of success. And then there's kind of secondary measures that kind of support those ultimate goals around supply security in terms of the number of suppliers you need per product, as well as ensuring that, yes, innovation is ongoing, so that when WHO comes out with a new recommendation, that innovation is happening to supply the right product as needed.
Thank you very much. Prashant, do you have a perspective on this? Performance measures, success, what will we put in our objective functions?
Yeah, so again, I don't know objective function or constraint, but I think equity, and this has become particularly important in the COVAX work, and this goes back to what I was saying about the distributional benefits, or in overall, not just looking at aggregate welfare, but how is it distributed amongst the countries. And that matters, in my opinion, as a performance objective, because if we create more, if we only look at the aggregate and say more kids vaccinated around the world or more kids on pediatric TB treatment, then we don't necessarily create stability in the purchasing pool. There are questions on, well, it benefits some countries more, it benefits other countries less. So that would be one thing I'll add to the performance objectives that Aurelia and Brenda put up.
Thank you very much. Another series of questions in the chat had to do with allocation of a scarce commodity and the challenges that you need to face, and comments around the fact that your pool procurement model gathers elements of cooperation, greater economies of scale and of buying power and so on, but also competition through these allocations. So in times of scarce supply, how do you, is this, you know, I know obviously for some cases it's been a big issue. How do you manage this? What's your perspective on this allocation rules? You've seen those questions in the chat, and the balance between cooperation and competition. May I start with you, Aurelia?
So the allocation question is absolutely critical, particularly when you think back about where we were in 2021, where the scarcity of vaccine was absolutely huge. A few countries had access to doses, the high-income countries, who a lot of them had production facilities on their soil that they could draw from, but many countries did not. And so as and when some vaccine doses became available, making sure that you had an allocation framework and an allocation mechanism that was independent and objective to the best degree possible was important. And so we actually had an independent committee and an algorithm underpinning it that basically made sure that we could ensure this level of fairness and equity in terms of how the doses were distributed. And then it also took into account, as more and more volumes became available, and I think this was another question that was put in the chat, how to look at those countries that were low in coverage but were ready to receive vaccines be prioritized over countries who were already starting to achieve higher levels of coverage. So it is a really important part in terms of having something that's robust. And to your question around, I mean, competition is a reality in global markets. And I think this is where the Gavi model is interesting, because on the one hand, we operate in some vaccine markets that are global, like COVID, like rotavirus, pneumococcal, but we also have vaccines that are very specific to developing countries where there is no, where by and large Gavi is the main procurer of a cholera vaccine, for example, of an Ebola vaccine. And so you really need to think about competition specific to your product, but ultimately recognizing that it's a reality. And so it's a question of the relative weight of your organization versus other procurers in terms of volumes, and also whether the critical mass exists in terms of the stability of the pool that you're operating in. And if that critical mass is there, then over time things can fluctuate, but ultimately the credibility of the mechanism relies on being able to give manufacturers a view to how much they should produce and be able to be a credible procurer over time. And if you can assure that, then you can absorb shocks within that. Thanks.
Thank you very much, Brenda. And I know, I'm sorry, Aurelia, and I know Aurelia has to leave due to a commitment. So feel free to say goodbye and receive our thanks, Aurelia, for your great contribution and starting this conversation. I'm going to go to Brenda and Prashant soon to give them an opportunity to answer this as well. But in the meantime, just please reminded that we will have an opportunity for 1 month from this date to continue in an online exchange facilitated somehow with these presenters, just because it's not enough time to really go as much as we'd like into these questions. So Brenda, what do you think on this issue?
No, it's a good question. And unfortunately, the reality of the TB market is that we exist in a normal environment involves rationing and prioritization and allocation. That's the norm for us. So all of our systems are built to accommodate that. And I think the worst case we had was at the beginning of COVID. We had kind of a number of things happen just before COVID. There was all kinds of changes in environmental policy in China that shut down all the API producers. Then COVID came and all the Indian producers were shut down of making the final product. Then the supply chains got hit. And here you're talking about, you have no inventory on the shelves anywhere. And you have all of these shocks coming at the same time. And we were able to kind of augment the processes we already had in place to deal with this. And somehow, miraculously, we didn't end up with any shortages anywhere. And that's for a number of reasons. One is we prioritize allocation based upon country needs. And in 56 countries, which make up 90% of the volume, we get quarterly data on what they have in stock, what they have planned to enroll, et cetera. So we know what they need, what they have now, and what they're going to need in the future. And whenever somebody comes in with an order, we always check to see, based upon this data, are they ordering the right amounts? And that information that we have on a regular basis allowed us to really say, okay, country A, you ordered 18 months worth of drug, but we know you already have 12 months in country. So we're going to send you 6 months now. We're going to give the rest to this one. And so we're able to do that kind of rationing and prioritizing and shifting volumes. In addition, we had the stockpile. So that was a good buffer for us. But really what you need is good relationships with your clients and your suppliers, because it's a lot of moving parts. We literally had weekly calls with our suppliers and our freight forwarders and whatnot saying, okay, move this one to this one. And because everybody's kind of committed to the goal and there's a long-standing 20-year relationship of clients and suppliers and us, it worked. There's trust, and that's important to build that partnership model into things. It can't be like a donor says this and you do it. And so I think, it's a very good example of how to manage those types of environments. Yeah, thanks.
Thank you very much for this answer. Unfortunately, due to time restrictions, time is too short here, so I must be bringing this to a close. Again, I'll say it again, we'll have other opportunities to exchange for 1 month from now on, and we'll see how interesting this will. This is going to be, how valuable. I want to just thank a couple of people before saying goodbye to everyone. So Beatrice Allen, managing editor of the journal, for supporting all the logistics organization. Thank you very much. Beatrice. Georgia, thank you very much for supporting this initiative and making room for this. My co-department editors, Pavitra and Anant, for many discussions that led to this first seminar. And all the participants, of course, for engaging and attending and so on. And then particularly the three speakers, Prashant, special note for you for organizing, coordinating, as well as you, Brenda and Aurelia. Thank you for dedicating some of your scarce time to interact with our community. We really, really appreciate it.
Jeremy, sorry, can I say one thing? We had asked Aurelia to present her research questions. I think she couldn't do it, but she put that in the chat, so that just remind everybody to see that. Thank you.
That's right. And I'll make sure that the questions in the chat are basically posted on the site as well.
And I also want to take the chance and thank Aurelia, Brenda, and Prashant. This was particularly interesting, and very much Jeremy, as well as Pavitra and Anant. This has been a nice start, and I'm sure we can improve. But and last but not least, Beatrice, who I could not do this job without her for sure. So thank you, everyone.